I've never been called chief. I kind of like it. That's great. Try to tell them at school that I'm on chief instead of chair. Go ahead, today we're going to be talking a little bit about various types of manipulation for the cervical spine. For those of you who have children or have had the opportunity to see this movie, Kung Fu Panda, there's two scenes in the movie that talks about the whooshy finger. The whooshy finger is this super secret Kung Fu technique that only the masters sort of know. So I've been telling the students that I'm going to teach the osteopathic whooshy finger for the cervical spine today. So we'll get to that in lab. Just review some of the outline, some of the things we're going to be talking about. I never read through the outline because you guys can do that. I wanted to really stick to a lot of stuff that I hope is more pertinent. Obviously, I'm not going to go through like I would a sort of basic anatomy OMM lab session. You all have had the anatomy, so I wanted to point out some certain things that I think were important in practice, important in sort of our day-to-day dealing with patients. I'm going to focus a little bit during the lecture on some of the medical legal aspects of manipulation around the cervical spine. I'll touch on some high velocity sorts of issues. We're not going to teach or do any high velocity specifically in the lab. I think it's one of those techniques that I know the students all want to get to, but most of the students here are going to get that next semester. But for you all, I think for a lot of you, it was a major sort of part of your manipulation classes. So I'm not going to do that because a lot of you already have it. I'd be happy to talk about it in lab and to go over it, but I will go over some of the things that you want to avoid for that type of manipulation. And part of and understand that when I talk about high velocity of the cervical spine, you know, in Shakespeare, it's, you know, I come not to bury Caesar, but to praise him. Well, I don't come to bury HVLA of the cervical spine. I really do come to praise it. It's just that from a medical legal perspective, if you use high velocity, it's going to be one of those things that you need to document a certain way and be aware of some of the statistics that are out there. And we'll go through some of that when we get to it, but I wanted to just kind of set you up for that. In the cervical spine, it's kind of important when we look at the atlas to remember that this transverse foramen is where the vertebral artery is going to have a chance to get sort of kinked. And we'll go through some slides in a little while to talk about why it's easier at that point. Remember that the superior facets are also called the lateral masses. Sometimes it gets confused with when you say lateral mass, do you mean, you know, the transverse process, or do you mean the articular pillars? And specifically, the lateral masses are where the occiput sits on C1. And when we go through some of the diagnostic procedures, these will actually slide, or apparently slide to some degree, left and right, forward and backward, with some a mild amount of rotation. But remember that C1 is responsible for about 50% of the ability of the head to flex and extend on the neck. The other six cervical vertebrae will pick up the slack as far as this flexion and extension is concerned. That's where you're going to see most of that. When you talk about C2, you're really talking about rotation, and it's responsible for about 50% of the rotation in the cervical spine. So that when we have individuals who have difficulty with either flexion and extension, one of the first things you ought to be thinking of as far as bang for the buck would be C1. If people are having difficulty with rotation, again, you're going to be concentrating on C2 because, again, both of those, C1 and C2, have got about a 50% of that range of motion. So for folks who say, well, you know, I got this low neck pain, I can't, you know, rotate, I can't, you know, cock it to the side, make sure that that's part of your diagnosis, at least your diagnostic workup, and it's important to remember that. The other thing I wanted you to take from this slide was that the spinous process C2 is the one you're actually going to find. You can't feel, technically, C1 when you put your fingers under the occiput. I mean, I suppose you could if you had really, really bony fingers and pushed really, really hard and didn't care about not pipping the patient. But the spinous process of C2 is the one that is most evident at the base of the occiput, and C1 is more anterior. And so there will be ways to evaluate C1 more laterally than posteriorly. Slide. Some of the things that we want to remember as far as the rest of the cervical spine, and what I wanted to sort of remind you is the spinous processes and the modified sort of aspect of what we might call a transverse process. when you're diagnosing in the cervical spine, there are two ways to sort of do that, and I'll explain. If you concentrate on the spinous process, if you're more posterior, when someone, and you're trying to diagnose whether something is side bent right or rotated right, or side bent left, rotated left, and we'll go through the mechanics in a moment. If you're more lateral, you're going to be diagnosing the transverse processes, and if you'll get fooled into thinking that there's a fullness on the left, and you say, okay, everything's rotated to the left. If you're really posterior, you might be feeling the spinous process. And so that fullness that you feel actually designates a rotation in the opposite direction. So as something that I want you to play with in lab, when you put your hands on the cervical spine to do a diagnosis, if you're kind of lukewarm and sort of lateral posterior, you're not necessarily sure whether or not you're feeling a spinous process which has been pushed to the left, which means they've rotated to the right, or that you're feeling the the transverse processes, and that they've actually, it's more from the left because they've rotated to the left. It's one of those things that we kind of don't necessarily think about, but I think it'll help from a diagnostic perspective, especially when we talk a little bit about muscle energy and facilitated positional release, which is one of the things that we're going to show you today, because I was hoping that many of you maybe haven't had it. And if you have, you haven't had a lot of it. So we're going to do that as a very nice technique. It's an indirect technique. So we'll have some direct muscle energy, some indirect facilitated positional release, and we'll teach you the whooshy finger. Slide, please. Just a slide to sort of remind that the combination, the range of motion for the cervical vertebra, and again, the flexion and extension is going to be in C1, rotation will be in C2, and then you can sort of see that, I have to make sure I don't blow this up, that a significant part of flexion, extension, rotation, side bend is going to take place at C4 and C5. So if you had to sort of like pick the two spots, you're going to do C1 and C2, and then C4 and C5 are going to be the big parts of the range of motion. And a reminder that C7 is more acting like a thoracic vertebra than it is a true cervical vertebra. When you get down onto C7, if you're trying to decide, well, is this lesion C7 or T1, remember that when you put your fingers on the spinous process, if you have them rotate their head, C7 is going to move, whereas T1 is not going to hardly move at all. So if you have them rotate, C7 will move, T1 will stay stable. So oftentimes when you think of the prominent spinous process, sometimes it won't be C7, it'll be T1. So when you go to do any sort of diagnosis or writing in your notes, that's just a quick little reminder that T1 is not going to follow. One of the things that's sort of important when we're talking about, like I said in a moment about HVLA, is to understand the mechanics of how the OA actually operates when you forward flex. This, in fact, is not a fractured vertebra. This is the normal motion of the OA. The OA has a tendency to translate anteriorly quite a bit, upwards of 4 millimeters when you tip your head forward. That's what allows that whole flexion and extension sort of thing to occur. The good news is that it flexes very easily, and it actually frees up the vertebral artery, and it's as it comes through and enters up into the head. The bad news is that if you extend, it tends to do the same thing in reverse, but it tends to be more likely to kink the vertebral artery. So part of the things that you worry about is that if you're going to do high velocity, that quite frankly, never ever do it in extension. If you're going to do it, it's much safer and far less likely to ever cause a problem if you're doing it in neutral and in flexion. So if you have any type of lesion of the OA that is in extension, then if you're going to do direct technique, you correct it in flexion. If it's in flexion, correct it in neutral. Don't go to extension. What we found is, and as I said, as we discussed it from a medical legal perspective, doing it in extension sort of signs your death warrant. If I found that it was in flexion, so as you're describing to the jury, I tipped the head into extension, side bent right, rotated left, and went ahead and provided a small thrust. That's not going to go well. So make sure that when you do this technique, that if you're using high velocity, again, which is fine, remember this huge amount of translatory motion that is in your favor in flexion and against you in extension. Some of the mechanics that you have to remember from for those who are taking your review boards, and if they have anything on there on Fryette's laws, remember that the cervical spine does not follow the classical law, Fryette's laws 1 and 2. When we have the spinal motion in neutral, side bending and rotation are to the opposite directions in the thoracic and lumbar spine. That's not true for the cervical spine. They are coupled, and so that you have a combination of side bending and rotation to the same side for C3 through C7 with flexion or extension. Now, the problem is that in OA, the OA, it's not coupled, and it's mixed. Whereas side bending and rotation to opposite sides, or a side bent right, rotated left, would be a normal type 1 Fryette's law. In the OA, side bending and rotation are to opposite sides, side bending right, rotation left, but there's a flexion extension component. So it's not a classic type 1 or type 2. And then for C2, it's very much the same thing, whereas typically the rotational component is the biggest part. Although you may have some side bending, it's mostly rotation. And that C2 also is in opposite types of direction. Can there be a flexion extension component to C2? There can be. It's not particularly common based on its anatomic structure. And if you're going to try and do a high velocity with C2, generally in neutral or a slight bit of flexion is again in your best interest, because we're still pretty high up in the cervical spine, and that vertebral artery is something that you want to go ahead and continue to be aware of. Cervical spine injuries are really common, unfortunately, and the part that I think is sort of the take-home from this slide is that, that with a cervical spine injury, almost half of them die at the scene of the accident. It's a very sort of common thing to have someone. I just had a patient in the office yesterday, or day before yesterday, whose son was killed on a motorcycle, took a turn a little bit too hard, and broke his neck at the scene. And she broke down, was crying, was telling me about it, and he had to let them know. She was so worried that he sat there and suffered, and that he felt like he was dying. And I said, well, the good news part of it, if there was any good news at all, was that the likelihood is that it was pretty darn quick, and from the way she described some of his other injuries. It's important to remember that that although the mean age of injury is 30.7, it's mostly in the youngsters. I just started riding a motorcycle for the first time last year after years of having my wife say no. And I swear that when gas went up to $4 a gallon, I heard motorcycle. She said scooter, but I heard motorcycle. So in any case, I strongly recommend that if you have any patients who have motorcycles or have teenagers that are thinking about that the Motorcycle Safety Foundation runs a tremendous course. They can get their license through it. The statistics are very much in the favor of the foundation. For those individuals who actually take the course, the death rate or the injury rate is statistically unbelievably better for those who actually take the course. So if you have folks who want to do that. Now, I mentioned motorcycles only because that's a common place that you'll see these young males injure themselves, but motor vehicle accidents are a big chunk of where we see spinal injuries or spinal injuries, and then sports injuries, certainly. One of the things that is really important when we talk about sports injuries is that oftentimes they will not necessarily be the athlete in the end zone who's hit, and then they run the team out there and run ice water through his veins to dramatically drop inflammation. These are the kids oftentimes that'll take a hit and they'll get up and they'll walk around. And it's really important, especially for those of us who practice some sports medicine or maybe the family docs at the football game, that an on-field neurological exam is very important. If we're working in the ER, you clear the X-ray, and boy, oh boy, please make sure you've done a really, really, really adequate neuro exam. And don't forget that the exam itself is only part of the deal. When someone talks about symptoms, if someone talks about, I took a hit, and I got this weird tingling in my left hand, and it persisted, and you checked him, and it's really, deep reflexes are okay, and motor seems okay, but I've got this weird symptom.
that weird symptom needs to be cleared with an x-ray. I mean, I got to tell you, from a medical legal perspective, the statistics are way against you if you just say, well, it's just got a little stinger, he's got full range of motion, he's a little stiff. When someone's got a neurological symptom that is there, and even if it's transient, I'm going to say almost 20 years ago, there was a Penn State linebacker who took a huge tackle on a kid, got some weird, stinger, paresthesias down at both arms, cleared on the sideline. They kept him out for the rest of the half. They got into the locker room, and the way it's described is he tipped his head back to drink a can, and he pithed himself and dropped like a sack, and he had fractured his dens, and then when he put his head back, he just popped it through his spinal cord. Really, really, really important these days that if anybody talks about it. Now, 4 or 5 days out, still got weird neurological symptoms. I got this weird tingling. I had an accident. A good doc friend who was a football coach, was a basketball coach, worked on the sidelines, had a kiddo who had taken a hit, had a headache, had this weird sort of symptoms. Saw him in the office. Neurological exam was great. Had full range of motion. Did a high-velocity technique, and he says, it just felt not right. Took an x-ray, and he had fractured C5. It's just really important when there's a history of some neurological symptoms, please cover the patient and cover yourself, and don't just say, well, everything else looks okay. It's very different when you've got someone who's come in that you've manipulated a bunch of times, they have chronic problems, you see them 3 times a year, and you know this patient, you know what they can and can't tolerate. But a new patient or someone who's got a new injury, don't miss it. Slide. Oh, I have to say that this lecture was called Cervical and Lumbar. I found out that we didn't have the use of the PowerPoints in the lab room, so I have abbreviated this to just cervical. And we can certainly talk about lumbar stuff when we get into lab, but for the sake of keeping you all out of tremendous comatose-like state, we'll stick to cervical today. So the 105 slides in the handout, the lumbar stuff, we'll sort of skip over. And individuals who have these injuries, like I said, there can be late complications, delayed recognition we talked about. Slide. X-rays are one of those things where they're going to keep you out of a lot of trouble. They're going to save your patient a lot of pain and suffering. Anytime you have anybody who's got mental status changes, who continues to have neck pain, we can call it whiplash, we can call it paravertebral spasm, but you don't know unless you've looked. It's really that simple. Any kind of midline tenderness, you're looking for spinous process, and again, any sort of neurological symptoms. This is the kind of the fake one. Now, I fell down and broke my arm. Should I get a cervical x-ray? That's not really what that means. However, if you're in any kind of an injury, whether it's a car accident and you break something, or you fall down and you break something, if there's any kind of a history where they struck their head, they got banged by the airbag, and they had any kind of transient sort of confusion or anything like that, and they come in and they're fine, you really ought to get the x-ray. Just don't miss that. It's just really important. And it's much more likely to have a cervical injury if they've got something else someplace else. Because you know that the amount of trauma to have to cause that fracture is significant. It's not like what Dr. Durham was talking about. Everything's connected. And it's not just like his arm went through the motor vehicle accident. His whole body did. So it's really important to recognize how important it is to follow up on that. Now, do all trauma patients with significant injury need C-spines? No. If they don't have any neck pain, there's no neck tenderness and palpation, full range, painless, active range of motion, no history of loss of consciousness, no mental status change, no neurological defect, and no distracting symptoms, okay, don't get the x-ray. But in a car accident, how often do you see that? There's going to be something. So the idea here is just to remember that if everything is wonderful and, geez, I just had a little fender bender and I cracked my knee, all right, fine. But if there's any history of any of this, you really got to do it. Good. So I get the x-ray and, x-ray's clear. Pretty good. Radiologist cleared it. I looked at it. It looks pretty good. It's one of those things where you take a look at this and that doesn't show up on x-ray. You miss it. But it's really important that if they had any of those other symptoms that are persistent, especially if I got an x-ray and they still got this weird paresthesia, get a CT scan. The MRI is not going to give you good bony architecture. The MRI is going to give you soft tissue injuries. It's going to give you discs. It's going to give you tumors. It's going to give you hematomas. The CT scan, though, it's going to be very helpful when you see any kind of a neurological deficit, or again, if you have a high index of suspicion. And I know that whole black box high index of suspicion, it could be just something funky. I had this injury. I got the cleared C-spine, and I've just got this weird sensation down the back of my leg. That's a neurological symptom. In cervical myelopathy, they could have no neck pain, but they've got symptoms going down the back of their legs. They've got this weird weakness. That's spinal cord until proven otherwise. So it's really important that if you get this little hint, just say, you know what, I'm not taking off this CT collar because you got a neurological issue. I don't care if it's clear. If you take off the collar and feel, I got some tenderness, well, maybe it's just a whiplash. In court, if that got missed, and up to 20, I think it was this one, up to 20% of fractures can be missed on regular x-rays, statistically, that's horrible. That's like 1 out of 5 clear x-rays and a fracture is going to be like normal. So again, use that high index of suspicion. Anything that even remotely resembles a problem, you need to follow up. Again, MRI is going to get more of the soft tissue. Good. Know all that. Go ahead. MRI again. Vertebral artery we'll talk about a little bit when we're talking about high velocity. Again, you don't like to necessarily, cover your patient with radiation, but if they need it, and you can't worry about it. Go ahead. And again, the high cost is an issue. Some of the mechanisms of injury are kind of obvious. This was my favorite because I actually did this on a trampoline 20 years ago. Heard several things pop and snap, and of course at that point I think I was just out of residency, and I thought to myself, I have fractured my neck. I came down on my head, felt my neck go, felt these weird paresthesias, and thankfully it wasn't a problem. I actually have a picture in the office if you guys want to see that, of where I was in the air, not the crash, but the air part was pretty impressive. It's important to recognize that axial does not necessarily mean a diving accident and falling on your head. One of the best cases that I ever saw was when I was an intern up in Waterville, Maine, was an individual who had a witnessed MI, grabbed his chest, and passed out. In the act of passing out, crashed into a tree. Just boom, bumped his head, went out cold. They immediately started CPR. The person who was with recognized it, called the ambulance, got him there. 3 days later, when he woke up, he was completely paralyzed. It's like, this is really weird. He had developed a Jefferson fracture, a blowout fracture of C1, and we had him on. He was on a ventilator. He was unconscious, and when they finally woke him up, he had broken his neck. But no one had bothered to look for that because it was all the MI. I witnessed the MI. So the trauma was an axial compression top of his head as he fell into the tree. When someone's unconscious, I know it was an obvious case, but sometimes you just have to make certain assumptions that there could be a neurological thing going on, and unfortunately he didn't make it. Hyperflexion is sort of a common thing. The days where airbags actually deploy, they still have a tendency not to deploy at times. You're still going to get this forward motion, even with the airbag. And although we're not going to have them hitting the windshield, you're still going to get some hyperextension. Hyperextension in and of itself is at high velocity is more than enough trauma to cause a fracture. It doesn't have to actually hit the windshield, doesn't actually have to do anything. So if somebody's got a lot of pain, say, yes, my airbag deployed, and they're splinting, it's not just whiplash until you prove it's just whiplash. Okay, next slide. We did the hyperextension, motor vehicle, yeah. So no, go ahead, yeah, Jefferson fracture. Just a nice picture of the typical blowout fracture of a Jefferson fracture with axial compression. Those are the folks wearing the halo. If we got to them soon enough and prevent any sort of neurological deficit. And what happens is the ring actually lets go and the lateral mass goes laterally, and you'll see a widening around the dens on one side versus the other typically. Go ahead. cervical spine herniation and rupture, again, the neurological exam is just everything in this regard. It's really important, but the take-home here is that they don't necessarily have to have neck pain. This can present itself with pain between their shoulder blades, pain into their arm, pain that you think is a rotator cuff. I got this persistent just ache, and I just can't get rid of it. In these individuals, when you really do a good history and follow-up range of motion as part of your exam, you're going to get some typical aggravation. They'll they'll have this shoulder pain, they'll have this back pain, and they'll be able to rotate one way, and they really can't. Oh, it just hurts too much in my back. Well, it may not be because it's a rib or it's a scalene that's in spasm. It's because it's the disc, and the pain is so great that that's the issue, and they can have no pain in their neck. So just remember that anything up in that high thoracic or up in the extremities can certainly be a disc. So as I mentioned, it can be, you can think of rotator cuff, but it can also be some other things. Geez, maybe it's a gouty, and again, uric acid is going to be negative in the cervical spine. I mean, for the cervical herniation. But that can say, well, I got this weird carpal tunnel, pronator teres sort of thing. I've got this, numbness. And it kind of goes up into my arm. You're thinking, okay, it's less median nerve down low. Maybe it's up high in pronator teres. One of the things that's very helpful is to ask them about their paresthesias, and are the paresthesias localized? I mean, we get a chart later on about just checking the dermatomes, but it's important to recognize that the median nerve is going to catch those first three fingers, the inside of the fourth finger. If they're describing it more like a glove type of sensation, or that it's more ulna, you got to be thinking, well, it might be kind of classic because he's got a weak grip, and maybe you're even seeing some thenar eminence over long-term atrophy. It could be up in their neck, and it's just important to do that thorough exam. Remember, I tell the students all the time, most of the time, just ignore where they're saying their pain is and look everywhere. If you're doing your full neurologic exams, they come in for, hand problems, and you don't do their neck stuff and you don't do ranges of motion, well, shame on you. It's not just about, I know we try to get people in and out sometimes, but, it's not median nerval tendinitis. If you didn't do the rest of the exam, you're going to be culpable. Go ahead. And also notice at the bottom of the left, just go ahead and flip back. Just important to remember that, again, we can be having symptoms that are down into the lower extremities, into the legs, shock-like, lightning-like, tingling in the torso and legs. Again, it's not just about where they're complaining, so make sure that you look up top. When you do have a cervical herniation and the patient doesn't want to go to surgery right away, or their EMG shows that maybe they've got a little bit of nerve entrapment, but they're functional, they feel like conservative care is okay, there's no distal myelopathy, it's more localized, and they're able to be managed. There's no reason to just jump to surgery. I mean, a disc herniation is not a death sentence. Is not a date with the scalpel. They can be managed conservatively. I mean, especially in younger folks, these discs will reabsorb. It's no different than the jelly from the jelly donut. This can be reabsorbed. You just have to be really careful about their management. Manipulation in these cases is perfectly appropriate under very strict guidelines. This would not be someone I would want to do HVLA on. From my allopathic friends, do we have any MDs in the audience? Okay, high velocity, low amplitude HVLA. That's not a person you're going to want to do something like that to. And generally, it's always going to be about patient feedback during the technique. We'll teach you some gentle, indirect techniques in lab that you can use. Indirect takes them away from their pain, takes them into their range of motion. So generally, those are going to be very well tolerated. Go ahead. If they get increased pain, if they get increasing dysfunction, all bets are off. And you have to remember that that as things get worse, if they're progressive, if there's any kind of an increase in neurological deficit, those are the folks that you may have to become a little more aggressive with your encouragement to visit the OR suite. Good. Just as a sort of a review, the spondylitic myelopathy is very common in the elderly, especially as they develop those anterior spurs on the bodies of the cervical vertebra. They can get impingement, and they'll give you, in the beginning, they'll just say, oh, I've got neck pain, and their neurological exam is really pretty okay. There's nothing to sort of clue you into it. You've been seeing them for years. Maybe it's just not a big deal. Well, it might be a big deal because, as you well know, the degenerative changes are going to be very slow, typically very insidious. Someone's not usually going to wake up not being able to move their legs because of weakness. They may have had a couple of what you thought was maybe a little benign vertigo. Just a couple episodes of 3 or 4 days of a little bit of vertigo. Came, it went. There was nothing that made you think any kind of a TIA. You had a little virus. You had a cold last week. And so it's important to recognize, especially over time, whether or not these symptoms are coming on more frequently and are increasing in number. If, I had a little bit of vertigo and now I've got this little bit of weakness, you got to have a high index of suspicion that their spinal cord might be being impinged on. Go ahead. We talk about the myelopathy, and it's not just always a degenerative process by any means. I mean, you can have certainly lots of other things, ALS and multiple sclerosis, tumors, hematomas. Those are all things that are important. So a follow-up with an X-ray is a nice start to at least give you the DJD, but it's not going to tell you whether or not the spinal cord is going to be really involved. Really, MRI is the way to go there. Go ahead. There's just some of the DJDs and some of the symptoms that they're going to see. And again, a little bit of leg weakness, a little drop in a couple of things happening over time. The person's 74 years old and they've had multiple illnesses. They've been a little debilitated. Well, I'm sorry to tell you, it's just a little old age. There's no such diagnosis as you're old. It's not a diagnosis. That might lead you to other diagnoses, but please don't tell your patients that, I'm sorry, it's your age. No, you missed the diagnosis. There's always a reason for something. It's just that if we don't know it, we have to be looking, and if we don't figure it out, then we have to get some help. Slide. The shock-like sensation is very typical for, anybody want to pronounce that for me? I think is Lermit sign, is that? Sorry? Lermit's. Hey, I love it when I guess right. This is actually not an uncommon thing. We actually had a student last year who developed this, who got these intermittent shocks down the center of their back, and they had developed a little bit of a spur posterior to the body, and they were actually catching part of their spinal cord. Now, thankfully, he was managed very easily with osteopathic manipulation. Not HVLA, mind you, because he got some spinal cord stuff, but just some gentle cervical traction and some manipulation has left him completely symptom-free. His EMG is clear, but he knows that there's an issue there. And so he has to be very careful in the types of things that he can do with athletics. Just more symptoms. Again, MRI is important. Yep. A list of all the other possibilities, and I just wanted to, again, try to give you one take-home from the slide. Vitamin B12 deficiency is actually fairly common in the elderly, and we don't help that by fixing their stomach with protonics and H2 blockers. Remember, the B12 needs to be activated. It's probably one of the most complex vitamins we have, and it requires, before it's absorbed in the ileum, it needs to be activated and have intrinsic factor and some acid to kind of get it going. One of the things you might want to remember is that, a little bit of weakness, you're old. Sometimes if we don't have a megaloblastic anemia, we think, it's not a big deal. You don't necessarily have to wait for someone to have a full-blown anemia before you check their B12. I can't tell you how many folks that I check regularly whose H&H is fine, but they've got this sort of weird. The indices are a little towards the high side. They've got these weird symptoms. You check their diet. They're not. I take a lot of Tums. their B12's off. And for those people, you don't necessarily have to inject them. The statistics show that just flooding them with oral B12 is very safe, and you can kind of overwhelm the weakness in their ability to absorb it by just simply giving them more. If you give them shots, that's fine, but oftentimes just a lot of extra oral supplementation can be very helpful. The other time that you may pick this up is someone who's got some atherosclerotic heart disease, and you're thinking it's their cholesterol, when in reality they've got a homocysteinemia because they've got a B12 deficiency. And the studies coming out of Stanford are showing that homocysteine is a valuable sort of thing to utilize, not only for inflammation and arthritis, but also for atherosclerosis. And B12 and folate are very important in homocysteine. Methylmalonic acid is, you can do a B12 level, but also methylmalonic acid and homocysteine levels will also give you a clue as to whether or not there's something going on in that regard. Remember that spondylitis, inflammatory, is oftentimes genetic and immune related. I only mention that because, as you heard, part of my love, although the homeopathy part is on the side, has nothing to do with this. But the functional medicine that I think very effectively utilize as part of my family practice and manipulative practice is to recognize that a lot of folks with these inflammatory conditions, whether it's rheumatoid arthritis, whether it's ankylosing spondylitis, whether it's Crohn's or whatever, a lot of these folks can have food intolerances, gluten, dairy, especially gluten, even in the absence of gliadin positive antibodies. A lot of these folks, a trial on an elimination diet, especially young adults, but not necessarily old. I had a very nice lady who was 75 years old who developed sudden rheumatoid arthritis out of the blue about 3 months after a tremendous intestinal problem, which lasted for weeks and weeks and weeks. And when it finally calmed down, within a few months, she developed rheumatoid. That lady developed gluten enteropathy. Now, she had a little genetic sort of predisposition. She had it under control for years and years and years. She was she was on methotrexate and all this stuff. We took her off gluten, and her symptoms are now 90% better. She's still got RA, but part of the issue is that it was a gluten-related thing. So oftentimes in individuals who have chronic neck pain, chronic inflammatory sorts of conditions, don't forget that sometimes their diet and some food intolerances can be a possibility. When we're checking for, but before we decide to do any kind of manipulation, it's always important, again, to do your standard and full neurologic exam. It's really important. The two that specifically test for localized individuals, now, depending on where you go, Wallenberg's may or may not be this test. I did a search, and some books say, yeah, that's what it is, and some say it's not. Just remember, we're testing specifically for vertebral artery insufficiency, and we're going to go ahead and back bend and side bend at the same time, rotating to the same side. And again, that back bending is that extension. And we talked about the vertebral artery is going to be more compromised because of the tendency of the OA to slide posteriorly. So we go ahead and we put them in that position. We hold them for 20 to 30 seconds. If you have an index of suspicion, don't bother to do it for just 5 seconds. It's not going to be necessarily beneficial. They can have symptoms within 5 seconds. You can put their head in that direction, and you don't think, you've already checked them. I really don't think this is a vertigo issue per se, but it may show up as a symptom, oh, I'm getting terribly dizzy. That's not necessarily a labyrinthitis. That could be a vertebral artery insufficiency that you just picked up and you just, manifested. You got to follow it up with MRA. So we can get dizziness, tinnitus, visual blurring, nausea, faintness. The nausea can often be related not only to the vertebral artery but also to the vagus nerve. So again, just because they have nausea and dizziness, maybe that is a true somatic dysfunction, temporal bone and the OA and the vagus are having an issue. But in my mind, it's a vertebral artery issue first and foremost, and then it's a somatic dysfunction. The other test that you want to remember is Sperling's. It's a great test. It's for foraminal compression. You're going to go ahead and side bend and back bend and then add some axial compression as you do that. And you're going to hold them again for 20 to 30 seconds. Now, the thing that's important to remember is that when you do it, if they get their symptoms and it comes down into their neck, it's really not a positive Sperling's until it goes past the tip of the deltoid into their arm. It can go down their back. It can go, but you don't necessarily know for sure. Now, in my mind, if you get the symptoms, to me, that would say, I could say equivocal Sperling's, and I'm going to go ahead and make sure, I get the MRI of their neck and make sure the vertebral artery is okay. But again, Sperling's is more for nerve root compression, whereas the vertebral artery is above. But the radicular symptoms don't have to be into their shoulder. If you give them compression in this maneuver and they get low back pain, It could be the myelopathy we're talking about. So remember that even though Sperling's is looking for a radiculopathy into the upper extremities, if they get symptoms someplace else, don't miss it. Some other, typical things that you can look at. A lot of folks will go ahead and present with swallowing difficulties that causes from their cervical spine. You may not have a whole lot of neck pain. You think it's a tertiary esophageal thing. They got these tertiary waves in the elderly, or they got this weird thing. I mean, it definitely can be something on the front of their spine, and a nice cervical x-ray is real easy to see if they have anything impinging on their esophagus. Again, compression test is very specific to the foramina, and the Sperling is just the side bending and the back bending a little bit as you compress with it. Valsalva technique, when people bear down, every time I have a bowel movement, I get this weird sensation in my left arm. Well, that doesn't make any sense. No, it makes a lot of sense. Okay, it's like the first thing you got to be thinking of is they're getting something in their arm, they're bearing down, there's something at the base of their head or in their cervical spine that you got to be worrying about. And then the distraction test, which people think of less, can have just as much of an impact as the compression test, depending on where the pathology is. Good. So mechanics in the cervical spine, again, we talked about this. Just remember that type 1 and type 2 mechanics aren't really applying. The OA is side bending and rotation. There's also we call that side slipping. When somebody side bends to the right and rotates to the left, we also call that left side slipping. So depending on the test that you take, for those who are doing, who have to do their boards, you may not see that it's side bend, right, rotate, left. They may have written it as there's left side slipping. Well, left side slipping just means the chin goes left, which is code for side bent them right and rotated them left. Oftentimes there can be a flexion or extension component, which we'll deal with in lab. AA is really more rotation. Again, when you go to treat folks with for the axis or for the AA, you're really going to have them flex a little bit, upwards of 40 to 50 degrees in people with spinal stenosis who have a lot of neck issues, and you really feel like you'll be able to get away with less flexion because they don't flex, and so you just deal with what you can. And then with the rest of the cervicals, they side bend and rotate to the same side, and usually there's a flexion and extension component. We did that. I put this in sort of as a joke, not because anybody in the audience is going to probably remember any of this, but because I knew there was going to be about 30 students. I want you guys to memorize this slide for the boards, okay? Go ahead. Let's see, horizontal plane, more rotation. Again, these are just as reminders. If you can just look at these, don't memorize it, but just if you're just trying to remember the mechanics, these can be helpful. And someone who is with diagnosis, almost got the wrong one. With diagnosis, remember that ease of motion is the way they can go. So when we're going to decide whether or not to do an indirect or a direct technique, it kind of reminds you. So if I can side bend right and rotate right, an indirect technique is going to bring me into right side bending and rotation. If I'm going to do a direct technique, I'm going to go in the opposite direction. I'm going to side bend left and rotate left to the barrier and then apply whatever I'm going to do. In the case of in lab, we'll do some muscle energy, and we'll talk about both the OAA and the typical cervicals. Kind of did that. Again, as a reminder, are you at the articular pillars, or are you at more posterior at the spinous process? If you slip your hands under someone's neck and you're using your fingers, you're kind of going to, and you just sort of, and your fingers touch and you're right there at the spinous process and you feel fullness, remember, it's going to be more likely the spinous process, and if you feel it full on the left, they're rotated to the right. If you've come up a little bit more laterally and they've got fullness, it's because they've rotated and side bent to that side. So just remember that from a diagnostic perspective. Go ahead. I threw this in just as sort of as a reminder that, with somatic dysfunction, after we've ruled out all the other sort of major issues, we've got lots of things that are from down in their back that can be causing problems up in their neck. You can have upper rib problems with scalene issues. You can have the trapezius spasm and trigger points and problems down in the middle of their back, which is going to refer and potentially cause the complaint of, it's my neck that's bothering me, without any back pain. It's really, really important from an osteopathic perspective, at least as far as manipulation and diagnosis, to recognize that you can have a latissimus dorsi problem, which attaches to their arm, which causes either shoulder dysfunction, and it's the lat that's the problem. It could be down in the upper lumbar spine, causing their shoulder problem, or because of the references to the shoulder and to the neck, a neck problem. Dr. Duramo did a great job on recognizing the whole tensegrity model, that picture that's outside of Bethesda, where you pull on one thing and the rest of the system has to react. So it's not unusual at all to have people with postural issues to be complaining about neck problems and no back pain. Had a perfect example of this, a lady who had, I don't know, 20 years of shoulder and neck pain. I ended up putting an 1/8 of an inch heel lift because it finally dawned on me that it's like, you know what, you're not paying enough attention to maybe something else is going on. She had no back pain. She had good range of motion. She had a little bit of a sacral imbalance. I put an 1/8 of an inch in, and the shoulder pain disappeared. And the neck pain disappeared. Again, remember the sort of distal connections. I guess I just did that. Go ahead. Remember also from an anatomic perspective that when you have neutral stuff in the thoracic spine, that it's oftentimes the long restrictors, the long muscles, the erector spinae that can be causing a problem. And recognize that we got connections down in the thoracolumbar junction, down into the sacral fascia that come right up into the neck. You just get these connections. So just don't forget that sometimes neck pain it's got nothing to do with their neck. Okay. So this panda, this overweight, sort of bumbling, happy-go-lucky guy, always wanted to do kung fu. He just lived for it. But he made noodles for a living. But he wanted to be a master. So he goes through this whole rigmarole called medical school, and after 2 years, he's this master of manipulation. We're going to talk about some of the specifics of manipulation. We'll go ahead and cover this now because, again, we can't do it in lab. It was designed to sort of do in lab. So as we are working on our ideas, again, not going to do it in lab, but I wanted to go through some very, very important things. High velocity, low amplitude. It's quick and short. In lab, we call it the quick 1/4 inch. It's not, let's get a running start from Toledo and see if we can get this thing to go. Okay? It's really important that if you're ever sort of taken to court, that you understand and recognize that when you describe it, well, I just kind of get in the neck and I just give it a pop. No, make sure that you understand. High velocity, low amplitude, very small motion, very quick, impulse thrust technique. I would leave out the rack and crack and crunch part if you ever had to testify. Go ahead. So we understand that high velocity, low amplitude should never be confused with high velocity, high amplitude. Okay? It's really important that any kind of manipulation you do it has to be based on diagnosis. It has to be based on what the patient can tolerate, and it's never about if you just hold still, I know I can get this. If it doesn't go, figure out another way, please. Good. So it's always about patient relaxation. Of course, we're going to be more likely to get damage if they don't. Try to get the patient to exhale. Now, I know some of you like to use respiratory cooperation in manipulation, and certainly you can do that for the thoracic spine. In the cervical spine, try to get them to relax as much as possible. And if you want a little extra oomph and have them inhale and then kind of hit it, if you're really, really, really skilled at it, great. If you're just kind of dabble at it, and I do it in a small percent of my patients, I strongly recommend you have them exhale and relax. Go ahead. Quick 1/4 inch. You don't have to hear, take home is, you don't have to hear a pop or a click. If you do the thrust, recheck it. Don't keep going till you hear the noise. Okay? It's just not necessary. All the time. And oftentimes, if you position it correctly, the students will tell you, if you position it correctly, it goes. And you can feel it slide. And there's no necessarily a pop. So always keep in your mind, it's not about getting the technique done. It's about constantly monitoring the tissue, making sure that if something just changed, recheck it. Don't just go ahead and do it. So you really want to make sure, again, that you're against the restrictive barrier. And then remember, when you get to the restrictive barrier, don't get this whole little loopy hip thing going, okay? I'm there. bring it back, and now I'm going to hit it. No, get to the barrier, and that's where the thrust takes place, at the barrier. There's no running starts in high velocity. Go ahead. Absolute contraindications. Now, some of you may completely disagree with some of this list. However, I've got to tell you that the Educational Council of the Osteopathic Profession, which is kind of oversees the manipulation of all the colleges, has come up with these, and it's important to recognize that even though you don't agree, from a medical legal perspective, if you use it, there's the sort of that educational perspective of the AOA that's telling you you shouldn't. So it kind of weakens your position a little bit. So again, if you're very skilled, it's not a big deal. Just recognize that if something were to happen, you could have a problem. Instability and Down syndrome in the neck, fracture dislocation and spinal instability, I hope are fairly obvious. You know, you can do high velocity and ankylosis and spondylosis with fusion, but again, you're taking a bigger risk, and there are just as many ways to do it without doing manipulation and clipophil. You know, you've got congenital fusion of 3 to 7 of the cervical vertebrae, so it's important to recognize that ranges of motion are important to evaluate beforehand. And of course, patient refusal is always an absolute contraindication. Hold still, this won't hurt a bit, is not okay. Go ahead. Again, absolutes, you know, really obvious sorts of stuff, acute myelopathy, acute neurological symptoms, anything that, you know, is unstable. Acute arthropathies, again, you know, osteomyelitis, you know, probably don't want to be doing, you know, stuff that just, you know, bad. Just don't do it. And then you get the relative contraindications. And people, now again, people would say, well, I wouldn't do it under that circumstance. Well, good. It's good that you wouldn't do it. I mean, if you feel like from your perspective, this is not a stable situation that you can go ahead and do, you know, high velocity or other kinds of manipulation, there's nothing wrong with not doing it that way. Find another way. But from a certain perspective, you can get away, I use that term very loosely, with other things. Now, no neurological diseases, you know, things like MS or ALS, you know, that's more systemic. Osteoporosis is definitely not necessarily a reason not to do it, but if you know that they're 4 standard deviations under, you might not want to do it. And then anything that you feel like, you know, medical legally, is this person trying to get me? Is this person trying to collect some money? That might be a reason not to bother. Acute strains. You know, acute strains is one of those ones where people come in with whiplash. Oh, just go ahead, you know, relax. Well, first of all, they're not going to relax. Can you do high velocity and whiplash? Absolutely you can. I don't personally do it. I'd rather get them a little looser and have them, you know, be making some progress first. But these are all things that you can go ahead and do. But again, you need to be tentative when you do it. Go ahead. You know, I'm sorry, I flipped the slide out of the way. You know, absolute, if they've got a positive Wallenbergs and Sperlings, you got to get the diagnosis first. You've got to rule out everything to make sure that, that you know, you do it. And I would even suggest that, you know, if you've got a positive Sperlings and Wallenbergs, you know, you need the diagnosis even before you do sort of indirect stuff, even before you just say, well, I'm just going to do some direct, you know, very gentle myofascial sorts of stuff. Okay, but if something happens in the meantime, when you send them out the door before you've made the diagnosis, it's going to be hard to justify that they're not blaming you, even though you may have nothing to do with it. Go ahead. Again, there's no reason not to do things, but again, you have to have it in your mind. Patients on anticoagulation, if they're unstable, probably not a good idea. You know, metabolic bone diseases, Paget's, things like that. Again, use your best judgment. Okay. The sort of the standard right now, medical legally, is Haldeman's and Vick's paper that originally came out in the Canadian Medical Journal, or Canadian Medical Association's journal. And it talked about high velocity manipulation to the spine in regards to unstable vertebral artery, an unstable vertebral artery, and subsequent damage to the artery or damage caused by manipulation that caused some sort of vertebral artery dissection or you know, caused transient or permanent neurological symptoms associated with disruption of the vertebral artery. It wasn't just you transected the artery. This is, you did manipulation, they got neurological signs and symptoms, and you're blamed for it. Now understand that a lot of folks will come in with neck pain who have got a vertebral artery problem, and that's why they have neck pain. It wasn't that the manipulation caused the problem. It might have extended the problem, certainly, but Kim, was it your buddy? Was it your buddy who was the surfer that got the vertebral artery? Girlfriend, yeah. Who came in with, neck pain. She got hit in the head with her surfboard, and she had a vertebral artery problem. So it's not like the only people that have vertebral artery problems are the people who get manipulated. Now, understand that this research, that to my understanding, and certainly if anyone's in the audience, correct me, please, I don't know of any suits or any specific details of DOs that have been involved with a vertebral artery issue. All of the findings that these folks found over 10 years, 10 years and an average visit of like 30 million manipulations, high-velocity manipulations in the chiropractic population, they found there were like 23 or 24 cases that were reported subsequent to high-velocity vertebral manipulation that caused a neurologic syndrome that could be attributed to the vertebral artery. From a statistical perspective, that works out to 1 in 400,000 to 1 in almost 1.5 million high-velocity manipulations causing a vertebral artery accident. Now, if you look at the statistics, we put 150 to 160,000 people in the hospital every year because of non-steroidal use. 15 or 16,000 of them die from non-steroidal use. We're more likely to kill somebody using non-steroidals than we are to hurt somebody doing high-velocity manipulation. From a statistical perspective, it's very, 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 very rare. Now, one of the things that they've been able to sort of glean from the research and from the people who have had these injuries is that the people who get any kind of vertebral artery problem, most all of those people had their manipulation done with extension as part of their setup. And so if you're going to do it, and you say, well, I've been doing it with extension for years and years and years, well, okay. But remember that if something does happen, and that's the way you've been doing it, if you've done it 50,000 times, maybe now it's 1 in 350,000, and you just got, 1 in 2,999. You know what I mean? Just be really careful and understand that from a medical legal perspective, high velocity is a very safe technique. It needs to be done correctly. You need to have your neurological exam completely done. You need to do a thorough history. You need to make sure that this person is not being set up to be one of the 1 in 1.5 million. That's just the research and the letter that came out, and just understand that again, these were done from the chiropractic visits, and that these injuries were not all life-threatening, but they were neurologically unstable and caused problems, and so you can. I'm sorry. This is where the study was done. That's where they got the research from the. Yes, I'm sure all American chiropractors never ever do it in extension. So they hopefully have learned from their colleagues. Go ahead. I put this in not to remind you of something that you already really, really well know. But again, the neurological exam can be done really quickly. And when the students were doing the sports medical, you drop your arms, you push out, you have them push their elbows against resistance, you have them flex their arms, you have them push against resistance for wrist flexion and extension, finger extension, grip, moving their fingers apart, and then doing your deep tendon reflexes. It's a great screening neurological exam. When it screens and something feels funky or not quite right, then it's time to really get really, really specific. I wouldn't do a screening exam in someone who's got what you think is a neck injury. It shouldn't be a screen. It should be a really thorough, really full-blown neurological exam. When we have people who come in who have been a big part of your practice, and I'm having a little neck pain, you do your thing, everything looks okay. Just remember that you've got to, at least as a basic, do the screen. You've got to do, when you do sensory, make sure you're doing, for at a minimum, intact for light touch. Make sure there's no weird, if there's a different sensation from one side to the other, all bets are off. It gives you, information that you got to follow up on. So, go ahead. So in lab, we're going to do a few things. One of my favorite things to just get started with is just you can do some soft tissue if you want, but I'm going to have everybody do an OA release. I know that you're going to need it, having sat here and gone into a coma with me blathering on and on. Again, you're going to dip those fingers in behind the suboccipital space. You're going to find the bottom of the occiput, and you're going to slip your fingers superior to that spinous process of C2. You're going to find that, and you're going to slide just a little bit more. One of the things that you can have folks do to really find that well is have them nod their head a little bit forward, get into that space, and then have them relax. And then it's just a gentle, steady holding of your fingertips there. Now, you're looking for a couple of things. You're listening to their respiration. You're looking for soft tissue relaxation. But oftentimes, when you start to do this, and if you start out with this, if they've, and I don't expect anybody in the room to have symptoms, but if they start to get any weird symptoms, it's time to redo your evaluation. If you trigger symptoms that are neurologic in nature while you're doing any kind of manipulative technique, stop, reevaluate, and make sure that what they're feeling is stable and okay. Go ahead. When we're looking for motion and palpation, again, you're going to just run your fingers down either side of the cervical column. Again, if you're real posterior, you're using the spinous process, which is fine. You can use that as a diagnostic. If you're a little more lateral, you're going to use those transverse processes and where their rotation. And what you're doing is you're lifting up, and then you're just kind of pushing the head back and forth, side to side. Rock it back and forth, and you're doing that motion testing so that you're feeling at your fingertips, where's the range of motion? Is it full on one side and less on the other? Is it more tight on one side? Good. So like I said, we're going to do some both direct and indirect. Remember that with an indirect technique, there's lots of different ways you can do it. You can use sort of a balanced ligamentous release, which some of you may know. You can use facilitated positional release. You can do counter strain, all very good indirect techniques. In this case, what we're going to do is you're going to take whatever segment you find. I've got this neck pain, and you really don't know what to do. You really don't want to do high velocity. You're pretty secure in knowing that this is a safe patient to do it in. Balanced ligamentous release is really nothing more than taking the individual vertebra through a range of motion, taking it to where it wants to go, adding a little bit of flexion and extension in where it wants to go. In other words, if it wants to kind of backward bend and kind of tip to the left and kind of rotate into the left, with your fingers at the apex of where it is a curve, if it's one segment, it's on the segment. If it's a curve, C 3 through 5, you want to pick C4 to get the whole curve. And then take them to that spot and leave them there. And I know that we're busy. However, you can do this technique in sometimes as little as 20 seconds. And as you leave them there, I want you to really feel at your fingertips for a shift or change in the tissue. You're listening to them breathe. You don't have to know cranial manipulation. You don't have to know about the Traub-Herring wave phenomenon of the nervous system. This is just a matter of getting to a position of relaxation and just waiting. And I promise you that 98% of you, well, actually, this is all DOs, so all of you, if you just wait, you will feel a sensory change occur. One of the students was saying, if I didn't have my eyes open, I would swear my hands were, doing this. As we use our sort of fine-tuned senses, you will pick up small changes in the tissue texture, and if you can just get a local change, maybe not like a pop or a click. I mean, that hardly ever happens when you do indirect techniques. It does, but again, local. It's tense. It's firm. You wait, and then it starts to give. Again, we don't do manipulation every week for the rest of their lives to keep them healthy and perfectly in balance. We do it so that we give their bodies an opportunity to do the rest. When we give an antibiotic, we're not curing the bacterial infection. We're killing enough of it so that our immune system takes care of the rest. That's the beauty of osteopathic manipulation. We're doing enough to hopefully get their body to take care of the rest. So if you can get something to just kind of move and they have this problem, get it to move, and that's all I know. You got it to move, see where it takes you. And maybe you do it 2 or 3 times over the next 2 or 3 weeks. Go ahead. Respiratory force and inherent force, it's just not moving, it's just not moving. Sometimes you can go ahead and have them inhale. If you pull in your fingers and it seems to go towards you, and then you push your fingers away from you and it's rock hard, pull your fingers towards you, take a deep breath and hold it. Encourage the flexion. If it goes away from you, have them exhale and hold it. Push it in the direction it wants to go, and then use respiration as a way to kind of augment what you're trying to get the body to do. Opposite, muscle energy. Muscle energy is one of those, a direct technique. It's a great technique. It's part of the whooshy finger, which we'll talk about in a minute. In muscle energy, we teach the students, and as a reminder, you have the patient do what they can already do. So in the case of someone who has a side bent right, rotated right lesion, inflection or extension, and they can't side bend left and rotate left, if you remember, have the patient do what they can do as the activating force, you've got muscle energy down. And I know that's very simplified, but think about this. If I can side bend right and rotate right, I'm going to go ahead and bring their head back to the point where I feel things start to lock up. I beat that restrictive barrier. And then I'm going to have them push their head back towards side bent right, rotate right. I'm going to have them just gently push back towards what they can do. Hold that for 3 to 4 or 5 seconds. And don't do it necessarily as just a matter of course. Okay, I'm going to cut 1, 2, 3. You can do that. However, if you're listening to their tissues while they're doing it, oftentimes you may want to say, hang on just a second, go to 6, go to 7, and you'll start to feel things shift and change. You'll feel the restrictive barrier change. If you just do it as a matter of protocol, and I'm just doing, it's not going to be as effective if you're listening to the tissues. You then go ahead and side bend left, rotate left a little bit more, and then have them bend back against resistance. It's not hard. If they push too hard, say not quite so hard. I got time. Okay, next one. Remember OA, side slipping left. We'll talk about that in lab. Next one. That's in your OA. Again, remember that it slides forward. Again, this was a review. Again, I put them together. We'll do that in lab. Again, muscle energy is forward and backward bending, so we'll talk about that. Go ahead. This, again, was part of the lab. That's why I'm going through it now, though. We'll talk about that in lab. Go ahead, just raising your head. Again, if someone's backward bent, and that's what they can do, I'm going to tip them forward in the OA and then have them bend backwards against resistance. It may be to raise their chin. They may, if they can't, if it's just too hard, you may just raise your eyes. You just have them, raise your eyes towards this, towards me. Look towards me. That may be enough to cause an activating force for the OA. Okay. And then nodding your chin back and forth for either flexion or extension, depending on what you need to do. Go ahead. Skip that. Skip that. We'll go to lab. Okay, facilitate position of release. It's a terrific technique, and depending on who taught it to you, there's 2 ways to do it. Now, as an indirect technique, if I can side bend right and rotate right, and I can flex my head, that's the position of ease, and that's where we're going to end up. But what we're going to do is, okay, I've already established that C4 is side bent right, rotated right, and flexion. I'm going to go ahead and take the head, put it into neutral. I'm going to put my hand on top of their head while I'm monitoring their neck, so one hand on the neck, one hand on top of the head, and I'm going to add a compressive force of about a pound or so, or a half a pound. It's just enough to feel your fingers respond to the compression. When I compress and I feel it there, that's enough compression. There's no, it needs 1.2 pounds for C4 and 1.4 pounds for C5. No. You're going for tissue release. Now, you've added the compressive force. You then gently guide the head into a side bent right, rotated right position while you're maintaining that compression. Remember, if you just tip their head off to the side, your hand's going to roll off and you're going to lose the compression. Make sure you maintain that compression and hold on to it. Typically, and still, they think that Still did a variation on this. Still technique's very similar. And you just hold it, and within 4 or 5 seconds, you should feel a dramatic shift in the tissues. And then as it releases, I want you to go ahead and then let the head come back towards the restrictive barrier after you feel something kind of soften in their head and bring them into side bending left, rotation left. Now, sometimes their head will come back and it'll roll around. Sometimes it'll just kind of drop and then move to the side. You're looking for, quote unquote, a release, and it's that soft tissue. But generally, it happens within a very short period of time, 5 to 7 seconds. Okay? That's facilitated position of release in a nutshell, and we'll go through it in lab. Go ahead. Again. Again. And we're not going to get to the lumbars. We may do it in lab if we have time. Go ahead. We're just going to skip through these. Yep. A couple things. Yep. Keep going. Okay. Cervical traction. Great for spinal stenosis. Great for chronic arthritic changes. Great for chronic neck problems. You can do it at home. You can get them in local medical supply places. It's an excellent adjunct to everything that you're doing. And especially it's also very helpful oftentimes for people who have disc pathology, but remember that you got to start out with very small weights and allow them to build up over time. Go ahead. Different kinds of cervical traction devices. They have lots of control with this type, with the insufflatory pipe. They still have control with the kind with the bag of the water. Go ahead and go backwards. No, go backwards, go backwards, go backwards. One more. They have control with their head. They oftentimes will use a weight, with water in a bag, and they can, as they let go of the bag, it adds the weight to the neck over the pulley system. But go ahead and go forward. Oftentimes they'll start to have discomfort and they'll have to grab for it, and then they get into this whole cycle of like, I can't grab the bag and I'm in pain and I'm going to hang myself. This one they have a little bit more control over. Go ahead. Remember that the traction should be as neutral as possible. It shouldn't be dipping their head way back, and it shouldn't be pulling their head into extension. It should be in a very neutral sort of position. Go ahead. That was just all anatomy. Doubt, get help. Questions? Okay, so we'll take a brief break, and then we'll meet you in lab in, 5 minutes?